there's just so much.
You're listening to a Mamamia podcast.
Hello, this is Well Australian Women. Welcome to your full body health check. I'm Claire Murphy, a journalist who, to be honest, I've spent most of my life breaking down some very complex stories for a living so we can all understand what the hell is going on. And my greatest skill, if I do say so myself, is I ask a pretty damn good question. And I have a lot of them when it comes to women's health.
And my name is Dr. Mariam. I'm a Sydney-based GP and a passionate advocate for women's health.
Today, we're going to continue our journey inside our wondrous pelvises, focusing on an issue that impacts up to 1 in every 7 women here in Australia. So many of my very good friends, and Mariam, I'm presuming so many of yours too, and that is endometriosis. Also later on, we're going to be doing another quick consult where we answer questions that you have sent in to us. This time it's for Tina, whose friend had a near-death experience and she wants to know the symptoms to look out for in case it's happening to her too. But first, today I learned something fascinating about women's bodies, so let's head off to med school.
Welcome to med school.
Mariam, I just read 2 fascinating studies. They both show that ovulating exotic dancers make more money off of lap dances than they do at any other time of their cycle. So the first one followed 18 women over 60 days, which means they did 296 shifts at the club, which equates to around 5,300 lap dances. That sounds exhausting. Hats off to you. They found that they made between $90 and $170 more when they were ovulating, which is wild. The second study, they filmed 48 exotic dancers performing different routines during various points in their cycle. 200 observers of those videos rated the near ovulation ones as significantly more attractive.
Love it.
Now, researchers believe there's a few things in here, like your face apparently is more attractive in that ovulation window, you're more confident, and you might even smell better.
Oh, my goodness.
What do you think? If we're off to the strip club, we need an ovulating dancer.
I love these studies, that they're even doing studies like this. We know that there's no real conclusive evidence about a woman's odour during ovulation. We need more robust sniff testing. What I think it comes down to is that estrogen peak during ovulation. It's that feel-good hormone. You know, you're at your peak in your mood, your confidence is high and your libido is high. So, you know, when you're a lot more confident, you feel a lot more attractive, and then that shows.
It's time for the checkup.
Okay, let's get into it. Today we are focusing, and I appreciate that you're wearing a yellow top today because we are talking about endometriosis.
Mm-hmm.
And coming up, we will be talking to gynaecological surgeon and endo specialist, Dr. Amani Harris. She'll give us the latest on the diagnosis, causes, and treatment of endo. Now, there has been some very welcome news when it comes to accessibility to treatment with a new drug recently approved here in Australia. Relugolix estradiol norethisterone, or RICO, is a daily pill for women with endometriosis who experience moderate to severe pain. The new treatment will also be listed on the PBS from May 1, which is amazing, making it much cheaper to access. So great to have another treatment option. But for anyone at the start of their endo journey or yet to receive a diagnosis, what symptoms should they be looking out for? Because we know they can vary quite a bit.
Well, everyone is very unique with their endometriosis experience. Generally, as doctors, we have like a list of symptoms that we look specifically when we're trying to diagnose endometriosis. And that includes chronic pelvic pain, period pain that is severely impacting your quality of life, pain with sex, and then you can have cyclical bowel and urinary symptoms. So you're getting like pain when you're urinating or there's blood in the urine, pain when you're passing bowel motions or there's blood in the poo. And for some, unfortunately, the first sign is difficulty conceiving as well. And that's not to say that there aren't other symptoms of endometriosis. There's a spectrum of symptoms that endometrious warriors experience, and it is each unique to their own journey.
Okay, so we've had this discussion about painful periods.
Mm-hmm.
But how painful does it have to be for you to think maybe this is endo?
So if it's impacting your quality of life, it's not being improved by medication over the counter, it's impacting your relationships, your work life, all of those things, you should definitely see a doctor to get that diagnosis excluded.
I've heard some people say it can be more painful than a heart attack.
You know, pain is subjective, so everyone's experience with pain is so different. There's actually posts on Dr. Harris's page, and she's like,
Dr. Harris is coming up. We're going to be speaking to her soon.
This is the pain that people with endometriosis describe, and it was like the lightning bolt, barbed wire, fire burn, stabbing, pulling down, and battery acid. Oh. So could you imagine? And we also often forget the mental health aspect side of it. So we know that many people with endometriosis suffer from like severe fatigue, anxiety, depression. It affects all quality of their life, from work to relationships.
Okay, so I saw this video on TikTok, which blew my mind. I want to know, is this true?
What was the most unusual place you've seen endometriosis in a patient?
In the eye.
In the eye?
In the eye of the patient, yeah.
Was that easy to excise? Did you have to send them to an ophthalmologist?
Yeah, ophthalmologist, of course. I did my surgery and then she was referred to an ophthalmologist. Yeah.
The doctor in question there said that the reason they figured out that endometriosis was in this patient's eye was because every month they would cry tears of blood. But like, can endo go anywhere?
Look, it's extremely rare to grow outside of the abdominal cavity, but it has. Like, there have been case reports in the lungs. Some people, like, their first presenting symptom is coughing up blood. There have been reports that it's like deposits on the brain. It can essentially deposit anywhere, but we see it most of the time within the pelvic cavity.
Diagnosis, Mariam. We know it takes years and years for women to be actually diagnosed with endometriosis. But how do we go to our GP and try and get to the point where we get an actual confirmed diagnosis with endometriosis?
Track your periods, write down a symptom diary. Ask your mum, your sisters, your aunties if they've ever had any painful periods, getting that information, because we know that increased risk with first-degree relatives. And then find that GP who subspecializes in women's health. Go in and say, I think I have endometriosis. Your GP should take more of a history. They should do an examination. We can't obviously confirm endometriosis on a clinical examination, but we can find signs which may suggest endometriosis. And for these GPs who subspecialize in women's health, we can start the process. We also have endometriosis clinics throughout Australia. So depending on where you're located, getting your GP to link you into one of those while you're waiting for that diagnosis.
Later in the quick consult, we're going to hear from Tina about her mate's close call with death and how she could tell if she's experiencing the same thing. But next in the checkup, we're going to speak to Dr. Amani Harris, an obstetrician and gynaecologist. We're going to get the latest in research and on the causes, diagnosis and treatment of endo. There seems to be breaking news on endo research every week at the moment. So I caught up with Dr. Amani Harris earlier to find out what's going on and whether any of these things are going to impact how we deal with it right now. Dr. Harris, you're a gynaecological surgeon, and I saw you posted a picture from one of your surgeries of inside a patient with endo, which just quietly is wild. How would you describe it to someone who can't see this? What does endo look like?
That picture got mixed responses. I really wanted to share it because often we talk about endometriosis and a lot of my patients don't actually know what that might look like inside. And the answer is, honestly, it looks so different in different people. And in fact, I get a lot of patients that have had a previous laparoscopy where endometriosis has been excluded and they've been told they don't have endometriosis. And then I do the laparoscopy and identify endometriosis, and that actually prompted me to run a study that we're doing now called Endo Color, which is why I'm really interested in the appearance of endometriosis, because clinically I see that it looks different in people. And the theory is maybe even that it might look different if they're on hormonal therapy, because we know that that might change the bleeding if they skip their period or not. Typically, people think of endometriosis as the black nodules because of the old blood, and that can be present. And I think the image that I shared did have those large nodules, but it can also be very translucent, or it can be really hard to see. It can be tiny little white spots, almost similar to icing sugar on the peritoneum, or really thick nodules if they dive into the tissue, deep into the tissue. They're the deep endometriosis nodules. So it can be small, it can be black, it can be translucent, it can be red, and that's quite vascular. And sometimes you don't see the nodule itself and you see the effects it has on the tissue. So it looks so different, and it's only if you've seen enough of it and you're aware that it may be different that you identify it.
Could some pain be the bowel rubbing up against those nodules of the peritoneum? Like, what is it that's causing the pain in there? I mean, if my liver was fused to my something or other, like, how would I know that that is the pain, or why is that painful?
That is the number one question with endometriosis. We do know that you can have people with very severe endometriosis in which it's caused the bowel to stick to the back of the uterus. Everything is frozen, and we call that a frozen pelvis because the endometriosis has caused adhesions, so abnormal connections between the different organs, and they have zero pain. And then you can have someone with very small superficial nodule with a lot of pain. It's strange in that the amount of disease, it doesn't correlate to the amount of pain. And I don't know that we know the answer for all endometriosis, but certainly for some women, the nodules themselves can involve pain fibers. They can cause abnormal function in the organs. Endometriosis doesn't respect anatomy, so it'll implant itself on a vessel. It'll implant itself on structures like the ureters in the pelvis or in the bowel itself or in the vagina. Typically, that causes pain with sex. They're the cases in which cutting out that nodule significantly helps with pain because it's a contact, it's a direct effect of touching something that is very inflamed and sore, and removing that helps. But there's other types of pain. So I don't think pain is the same for everybody with endometriosis. I think endometriosis is one thing, and then we as individuals are very complex, and we bring a lot of other things with us as humans, as individuals, that also play into pain. So I don't think people experience pain the same way, and I don't think it's just about the nodules of endo. It is for some people, and they're the people that you remove the nodule and their pain goes away, but it can be a lot more complex for a lot more people.
Where do you stand on hysterectomy as a treatment pathway for people with endo?
There's not one thing that works for everybody. I think it's definitely true. It is not a cure for endometriosis because nothing is. Someone can have a hysterectomy, removal of all endometriosis, removal of ovaries, be technically surgically menopausal and still have symptoms of endometriosis, whether they're inflammatory or pain. And that's where the underlying reasons people experience pain come into it. So it's really not one treatment option. It can help if there is other symptoms related to endometriosis, so specifically adenomyosis. It is a cure for adenomyosis. I think about 70% of women with endometriosis may have adenomyosis, and that's the endo in the muscle of the uterus. So the muscle gets big. It has islands of endometriosis within it. So within a cycle, you get little episodes of bleeding. It becomes heavy. It's a hub of inflammation, and it causes symptoms of inflammation. Again, people might have it and have zero symptoms, or have very mild adenomyosis and experience everything, including the heavy bleeding, the cramping they typically describe as labor pain or contraction pain, pain with sex, bloating. And for those patients, a hysterectomy will help those particular symptoms, but not symptoms related to other endometriosis.
What's the latest that we know about what causes endometriosis?
It used to be, so even when I was training, the thought was retrograde menstruation, or the old school Samson theory. And I really think that most in the endometriosis community have moved on from that. So that idea, I think, is out the door. We don't have an answer yet. I think it's good that we are exploring all the possibilities. And I know that menstrual blood has become another area that we're looking into. And now the thought, maybe it's, I guess, a more sophisticated way to look at Samson's theory, which is not the blood itself coming back through the tubes, but maybe whatever's in the menstrual fluid that predisposes women to endometriosis, whether they're particular genetics, protein, and I think there's now lots of research into this area, whether those proteins themselves retrograde back in through the tubes and into the pelvis and deposit. So that's one theory. There were other theories that we just carry the genetic material. We don't know what it is yet. We know that endometriosis does run in families. It's a big risk factor for someone if they have their mother or sibling, sister, or someone within the family with endometriosis. That increases their risk. So I think there will be a genetic component. There's other theories related to, I guess, exposure to testosterone within the womb, and testosterone has a big link to pain sensation as well. And we know that women or anyone with endometriosis has more pain sensitivity perhaps. So I think a lot of theories are being studied. We don't quite know yet.
Of course, the big conversation around endo is just how long it takes for people to get an actual diagnosis. Are we any closer to getting something like a blood test or using menstrual blood in order to figure out if you actually have endo or not without having to have surgery to make sure?
I've seen saliva tests, blood tests, menstrual fluid tests, and other biomarkers in blood particularly. I think they're all haven't been established for population-wide. That's why they haven't been introduced population-wide. To my knowledge, there's no one particular test that has passed everything, but I think it's good that the research is ongoing. I think we'll get there one day, but we don't really rely on surgery to diagnose endometriosis anymore, as in people don't have a laparoscopy anymore to diagnose endo. One, because it shouldn't stop them from accessing treatment to endometriosis. We really should be treating people based on their symptoms and even investigations in terms of assessing them with a vaginal examination or their history taking. And you can learn so much and really in our minds as clinicians know what the chances are of this patient having endometriosis first. And we shouldn't wait for a laparoscopy. In Australia, we are very lucky to have, we're world leaders in ultrasound diagnosis for endometriosis. I cannot remember the last time I did a laparoscopy that was negative because we use these tools now. They haven't gotten there yet for superficial endometriosis, but they're advancing their technique and training to perhaps even be able to diagnose superficial endometriosis. But definitely for deep nodules and nodules that may affect other organs such as the bowel or ureters, ultrasound has become key in diagnosing the condition.
What about the latest in treatments? I was reading that they're currently doing some study at the Royal Hospital for Women where they've grown all the different types of endometriosis to see if different types of endo respond to different types of treatment, which is really interesting. But where are we at as far as treatment goes? Because as far as I can see, surgery still seems to be the gold standard.
So I think this is probably one of the most exciting areas, and I think there's so much potential for it. And I think with this study, we can find out that particular type of endometriosis in each person and whether or not it will respond to estrogen, it will respond to progesterone, which type, or a combination. And I think it'll save people a lot of trouble and side effects and maybe even years of going through one and the other until they find the right treatment for them. So I think it will be hopefully a big game changer in hormonal therapy.
A massive thanks to Dr. Harris for sharing her expertise with us. Dr. Mariam, what are your top line takeaways from what you just heard?
How amazing is she?
Yes, she's gorgeous.
She's amazing. So what she started with was really important. So she was saying she had a patient who had seen a gynecologist, had a lap done and was told you don't have endo. And then she's done the lap and you do in fact have endo. This is where I tell patients it's really, really important that when you do see a gynecologist, that you're seeing that gynecologist who has done that subspecialty training. It makes such a world of difference. And obviously she's described endo as looking so different from patient to patient. So it's like really interesting to think that we could potentially diagnose endometriosis with a biomarker and then be told what subtype we have. And then all these endometriosis patients won't have to go through all that trial and error of like, let's try this, let's try this, let's try this. It's like tailored medication regimen based on whatever subtype they have. So that's really exciting that that's in the works and hopefully something that we get answers to soon.
I think, getting to the point of it quicker is going to be a big relief for some people.
Definitely.
Up next, we're off to the clinic for a quick consult. Tina wants to know if it's a panic attack, heartburn, or a heart attack after her friend nearly died on the side of an Aussie freeway.
The doctor will see you now, just through here to consult room 1.
Thanks for waiting. How can I help you?
Oh, I love being welcomed into the consult room. This is where you can have your health concerns heard. If you do have something you want to ask Dr. Mariam or any of our experts, make sure you reach out. We have an email, well@mamamia.com.au, or leave a voice note. You'll find a link to that in our show notes. Okay, so Tina reached out to us with this story, and quite frankly, I would also really like to know the answer to this question, because she wrote,
a friend of mine recently had a heart attack while driving along a busy freeway, but luckily she recognised the signs, so managed to pull over, get some help, and she's now okay. But she's 44 years old, had been eating healthily, exercises a lot, and had even given up alcohol in the last year. So really seemed like the least likely person for this to happen to. So what I'm wondering is, are there signs I should be looking out for? And how do you tell the difference between, say, some bad heartburn or the symptoms of a panic attack and whether you're having an actual heart attack?
this is really important because we have been educated so well on what a heart attack looks like for a man, but less so for what a heart attack looks like for a woman. What advice have you got for Tina?
So great that she stopped and she was able to recognize those symptoms and seek help. So actually studies show that females are less likely to call for help because they feel like a burden, and they kind of try to convince themselves, oh, it's just reflux or it's just my anxiety. Or if they do seek help, they're told those things, which is really unfortunate. And I think there's a big shift in attitudes now because we know that cardiovascular disease is one of the main killers of Australian females. And I know she mentioned that she had a healthy lifestyle. She doesn't smoke, she doesn't drink, and she was physically active. It's really important to understand that family history has a big part to play in this. You know, habits that you had in your previous life, whether you were an ex-smoker or a heavy drinker, they can still kind of increase your risk of developing a heart attack. So unfortunately, it can happen to everyone. Obviously, we always advise, you know, being physically active, reducing your alcohol, and quitting smoking or vaping if you do either of those to reduce your risk of a heart attack. But you're not completely in the clear if you have a significant family history. In females, as in males, chest pain is generally the cardinal sign of a heart attack. And females describe that generally as like a crushing chest pain. But for females specifically, they might experience other symptoms, and they don't always get the chest pain, the crushing chest pain. So they might feel fatigue, shortness of breath, or lightheadedness. They might have symptoms of indigestion. They might have shoulder, neck, jaw, or back pain. They might have pain in the arm, either one or both. And they might have some nausea or vomiting or sweating. Generally for females, they'll feel this at rest and when they're exerting themselves, and they usually get some warning signs prior to the big heart attack. So they might have, you know, several of these little, is that a bit of indigestion? That's what a lot of females will say. Oh, was that a bit of, and then they might have that happen several times throughout the day before. So they're warning signs. And I really want to advocate for all females, do not feel like you are a burden to the healthcare system. Men go to emergency all the time and they're seen within 5 minutes for suspected heart attacks. If you are having any symptoms and you just feel like something's not right, don't wait for that heart attack. You're getting the warning signs, that's your sign to see a doctor. And this is also a reminder for females that prevention is better than cure. So whenever I see a female, I'm like, have you had your heart health check? And they're like, oh, you know, I'm only 40. No, prevention is better than cure. So we can get on top of all those risk factors earlier.
Thanks for joining us again on Well today. Again, if you have any questions about what we've discussed or any health concerns you want us to look into, shoot us an email, well@mamamia.com.au, or of course, leave us a voice note. We want to hear your beautiful voices asking us questions. If you're interested in anything you've heard here today and want some more info on it, make sure you sign up to the Well newsletter. There's a link in the show notes for that. And of course, the advice you've heard here today is general and may not suit your exact needs. So make sure you reach out to your own doctor or health specialist to get the info that is absolutely 100% correct for you. And we'll see you for your appointment again this time next week.
See you next week.
Well is produced by me, Claire Murphy, our group executive producer Georgie Page and senior producer Sasha Tannock, with audio production by Scott Stronach and Jacob Round.
Mamamia acknowledges the traditional owners of the land we have recorded this podcast on, the Gadigal people of the Eora Nation. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander cultures.
Hi, I'm obstetrician Dr. Patrick Maloney.
And I'm Bridget Maloney. We're the hosts of The Kick, the pregnancy podcast that breaks down everything you need to know about making and growing a tiny human.
We cover it all with expert information and evidence-based discussion based on our experience of running a women's clinic and being parents to 4 boys.
From morning sickness to birth plans, strange cravings to baby movements, listen to The Kick wherever you get your podcasts.